Good afternoon, everyone. My name is Professor Tony Cunningham from the Westmead Institute for Medical Research and the University of Sydney. Thanks to the Immunisation Coalition for asking me to talk on herpes zoster and the two vaccines which have been developed for it. Firstly, I'd like to acknowledge the traditional owners of the land here in Parramatta, the Darug people of the Eora Nation, and pay my respects to their elders, past, present, and emerging. Now, herpes zoster is one of three vaccine-preventable diseases afflicting the aging, and in fact, there are now 5. I've only shown 3 here: influenza, invasive pneumococcal disease, and herpes zoster. And you can see how they go up in terms of affecting disability life years. And we now can add to this COVID prevented by RNA vaccines, RSV, now with an RSV vaccine available, and to a lesser extent, pertussis. Now, this is because in the aging, there is immune decline. And almost all modalities of immunity decline, including shrinkage of lymph nodes, a bit like what we see in patients with AIDS. And shingles is a particularly painful disease that can have serious and long-lasting complications, as I'm sure many of you are aware. So it affects the nerves with pain, the skin with a typical papulovesicular rash, and complications may occur, such as postherpetic neuralgia or persistent pain defined as that beyond 3 months after the onset of the rash. And this affects up to 30% of patients with shingles and increases with age. Ophthalmic zoster affects up to 25% of patients with shingles, less directly in the eye, and this may rarely lead to vision loss. And then there are other complications, such as ones we've become recently aware of, the increased incidence of stroke in the first 6 months after herpes zoster, and several others. And these symptoms of herpes zoster and complications may be more frequent and of longer duration in immune-compromised patients. This shows simply the severity of pain, whether it be acute or chronic postherpetic neuralgia. And you can see, as shown in red, that herpes zoster and PHN are right up there with the most severe causes of acute and chronic pain, which may lead to changes in the quality of life, impairing sleep, enjoyment of life, general activities, mood, such as depression after postherpetic neuralgia, and even walking, such that shingles can precipitate admission of aging people to aged care facilities from which they may not emerge. This simply shows you in most of the OECD countries that the incidence of herpes zoster climbs quite markedly over the age of 50, and postherpetic neuralgia tends to go up a little bit later, after the age of 60. And if we look at the pathogenesis of herpes zoster, 99.5% of adults over the age of 50 are infected with this virus in temperate countries, and therefore are at risk for shingles through reactivation of the virus. So chickenpox is controlled by the immune response, but the viremia and perhaps nerve transmission leads to infection of the dorsal root ganglion or trigeminal ganglion, and the virus becomes latent for life and then may reactivate once or twice, giving rise to herpes zoster. 1 in 3 people will develop shingles in their lifetime due to viral reactivation, and this rises to 50% of people over the age of 85. The incidence rates are similar through North America, Europe, the Asia Pacific, including Australia, of 6 to 8 cases per 1,000 person years at age 60. And each year there's an estimated 1 million new cases of shingles in the USA, 1.7 million in Europe, and 1.5 million in China. The reason for this reactivation of the virus is shown here, and it relates to T-cell immunity rather than antibody mediated immunity. And you can see the rise in T-cell responses after chickenpox declining and then being boosted intermittently through contact with chickenpox throughout life, particularly mothers with their kids. And then at around age 40 to 50, there is a decline in this T-cell immunity beyond a certain threshold, which is poorly defined. And this is the risk for the development of herpes zoster. So my colleagues, Myron Levin and Mike Oxman, the USA, figured that maybe you could boost this with a chickenpox vaccine, the live attenuated chickenpox vaccine, concentrate it and call it Zostavax. And in their landmark 2005 trial, they showed that there was a 51% efficacy overall in people over the age of 60 against herpes zoster, which declined to 38% over the age of 70, although 2/3 of people were protected against post-herpetic neuralgia. And unfortunately, there is a decline, a waning of this protection over a period of about 8 years. And so the live attenuated vaccine has been our first attempt, if you like, at vaccines for herpes zoster and has been licensed around the world. However, the second generation vaccine, Recombinant Zoster Vaccine, or Shingrix, consists of a single recombinant protein, glycoprotein E, found on the surface of the virus, which is produced by recombinant DNA methods. And this means that it's much easier to produce this vaccine. There have been problems in supply sometimes with the live attenuated vaccine. However, if you take this single protein, you lose the immunostimulant activity of the lipids and carbohydrates within the vaccine. So it's necessary to replace these with immunostimulants or adjuvants. And in fact, the adjuvants chosen proved to be a bonus because they did better than the natural immunity. And they consist of MPL from the cell wall of Salmonella and QS21 from the bark of a South American tree called Qualagia saponaria, that's why it's QS, bundled into a liposome. And the benefit of these adjuvants is to increase the immune response acutely, to increase its durability and increase its breadth. And this is well shown here. In orange is the immune responses to the recombinant zoster vaccine in people over the age of 50, 60, and 70. And you can see that about 90% of people are responding. If you leave the adjuvant out, however, you can see the response declines to 10% over the age of 70. And so with these encouraging results, we went on to phase 3 trials, the Zoe 50 and Zoe 70 trials, which were run concurrently as randomized, observer-blind, placebo-controlled, multi-center trials in all continents. And the Zoe 50 refers to patients recruited over the age of 50. Zoe 70, people recruited over the age of 70. And this is really to provide an admixture of older people to ensure there is adequate numbers to look at the effect on post-herpetic neuralgia. So in essence, we wanted to look at herpes zoster efficacy and post-herpetic neuralgia efficacy. And to our surprise, what we found is that in Zoe 50, 97% efficacy. You compare that to the 51% efficacy of Zostavax. And this was seen in people over the age of 50 and 60, and even better in people over the age of 70, over 90% efficacy, and these error bars overlap. So there's not really much difference between the two trials statistically, but notice that over the age of 80, there's even an efficacy of over 90% over a period of 3 to 4 years. And this was rigorously defined herpes zoster diagnosed by PCR or by a panel of experts looking at the characteristics of the rash, which was photographed at different stages of evolution. And similarly, the vaccine efficacy against post-herpetic neuralgia in both Zoe 50 and Zoe 70 was about 90% and over 90% against other related complications, which is encouraging. In fact, the efficacy against post-herpetic neuralgia was due to the efficacy against herpes zoster. We didn't see additional efficacy against PHN in people who were not, who had breakthrough herpes zoster. The most recent studies have now shown that this is a highly durable immune response. This is quite amazing for this group of aging people, that up to year 10, there is 89% efficacy against shingles. Drops off a little bit in years 9 and 10, and these studies are now going on in our centre and others up to year 15. And this is good news because it means that you can immunise people, say at age 60, and hopefully you'll get duration of immunity up to 10 to 15 years, and they won't need immunisation again, perhaps until then. Now, there's a bit of a price for this high efficacy, and that is, as we've seen with the RNA vaccines, increased reactogenicity, with 60 to 70% of people complaining of a sore arm, and in about 9 to 11% of these people, this is sufficient to impair daily activity for only 2 to 3 days, and it's associated in about 20 to 30% of people with redness and swelling. Similarly, systemic symptoms of fatigue, headache, myalgia, shivering may occur in 20 to 40%, and in about 9 to 10% of people, that's sufficient to impair their daily activities for a couple of days. And we're all used to this with the RNA vaccines. There was no difference between placebo and Shingrix in terms of the effects on serious adverse events. And people often ask, can you use this vaccine as a booster after Zostavax? And this is important where we've got high Zostavax coverage, as in this country, over the age of 70, over 50%. So fortunately, we know that the vaccine is equally immunogenic and safe in people who've had prior Zostavax, and the same is true with people who've had prior herpes zoster. And the recommendations are to use the vaccine in both cases after about a year after either prior Zostavax or prior herpes zoster. You can also use the vaccine concurrently in the opposite arm with influenza vaccine if it's unadjuvanted. It hasn't been really looked at with the adjuvanted vaccine MF59 adjuvanted vaccine fluad, with pneumococcal vaccine, particularly PPV23, and with diphtheria, tetanus, and pertussis, both safe and immunogenic. Now, if we summarize some of these, the vaccine is 90% efficacious against herpes zoster and complications. It's unaffected by age. You need 2 doses, but these can be given at 2 to 6 months apart, and the compliance in real-world setting does seem high. There is this high reactogenicity, but it only lasts 2 to 3 days, and only 1/3 suffer who've had severe reactogenicity with the first dose will get it with the second dose. The duration of efficacy I mentioned is long after 10 years. We do need to follow up for a longer period of time to make sure with these new adjuvants that there's no unforeseen effects, say, on autoimmunity. There's certainly none seen so far in the trials. Now, there are some recent advances with the recombinant zoster vaccine. The high vaccine efficacy is unaffected by the presence of multiple comorbidities or frailty. And frailty has been an issue for influenza and pneumococcal vaccines. The vaccine, recombinant zoster vaccine, also ameliorates pain in the acute stages of breakthrough zoster, not just with preventing post-herpetic neuralgia. And community effectiveness studies show a single dose is 15% less effective than a standard double dose. So you've got to use the double dose. And interestingly, good immunogenicity from the vaccine is not associated with reactogenicity. There's only a weak association there. And perhaps sometime in the future, we'll be able to retain the immune response of a modified vaccine with even less reactogenicity, something we are working on. Now, what about immune-compromised people? We've talked a lot about the aging. Here are the severe immune-compromised groups in which the recombinant zoster vaccine is being trialled. Different numbers, and only 2 of them have actually looked at efficacy properly. So we're looking at autologous stem cell transplantation, hematologic malignancies, renal transplants, solid tumors receiving chemotherapy, and HIV, which is less of a problem these days with the use of antiretroviral therapy. And if we look at the results which have been published in these rather difficult trials run for 1 to 2 years, we can look at antibody immunogenicity, T-cell immunogenicity, and in 2 cases, efficacy against herpes zoster, which has been 67% in autologous transplantation, 87% in hematologic malignancy, and just recently we've seen about the same level, 70% efficacy for renal transplantation. Now, as far as the reactogenicity is concerned, this was similar to the immunocompetent for local reactogenicity, but there was quite a high incidence of systemic side effects, which was mainly due to the underlying disease, as similar levels were seen in placebo recipients. What are the problems and issues for immune-compromised people? Well, we need phase 3 trials in subjects with solid organ transplants and malignancies to be completed to determine efficacy. We need longer duration of those trials than 1 to 2 years that we've looked at so far. We need real-life effectiveness studies, and we need to look at the moderate immune-compromised group, particularly those people receiving so-called anti-rheumatic drugs, which occur in many of the autoimmune diseases, including bowel disease and rheumatoid and SLE. And the one that stands out amongst these anti-rheumatic drugs is the JAK inhibitors. They give rise to almost a 5-fold higher incidence of herpes zoster than the other types of T-cell inhibitors. But you can imagine if you're looking at a drug that might inhibit T-cells, then the concerns are how well is this going to work for a vaccine that depends on stimulating T-cells. Well, there are 4 phase 3 trials in progress at present to look at this. And the early trials show reduced immunogenicity in the immunocompetent, and as one might expect with adjuvants, is there an incidence of increased rheumatoid flares? And some studies have suggested yes, and some have suggested no. So we're still waiting for the definitive data to come in from phase 3 trials. And this shows, one, indicating that you get pretty good antibody responses from baseline to 1 month after the second shot with JAK inhibitors and with other anti-rheumatic drugs and in healthy controls. There are other studies which are not yet published which show slightly less than this. So let's just look now at the recommendations in Australia for these vaccines. Both immunocompromised and immunocompetent people aged over 50 years should have recombinant zoster vaccine to prevent herpes zoster and its complications. In immune-competent people aged over 50 years, recombinant zoster vaccine is preferred over Zostavax for prevention of herpes zoster and its complications. For those people over 50 years or immune-compromised, Zostavax is contraindicated. We've seen deaths in people with hematologic malignancy. Shingrix or recombinant zoster vaccine should be used, and it's recommended for those people in this category over the age of 18. You can use Zostavax for immunocompetent people over 50 years if Shingrix is not available or affordable. This issue of affordability is currently being addressed by PBAC, and there are submissions to try and put Shingrix onto the NIP and also perhaps for immunosuppressed patients, and we'll wait to see how those deliberations play out. And finally, if we look at the use of and licensure of Shingrix around the world, it's registered in 35 countries, and there are varying degrees of preference. The blue countries have recommended Shingrix alone and have phased out Zostavax. The orange countries have recommended, like Australia, preference of Shingrix over Zostavax, and the yellow countries have recommended both with no vaccine preference. So I'm sure we're going to see this expand over the years, particularly into Asia. Thank you very much.
Well, hello everyone. Glad to answer your questions. And the first question is, do I have any concerns about giving Shingrix to someone with a past history of Guillain-Barré syndrome? And the answer to this is yes, one needs to be cautious in any person with a history of Guillain-Barré syndrome. This is associated with vaccines, particularly with influenza vaccine. It's very variable, and Guillain-Barré syndrome occurs after influenza as well. It has been shown to have an increased incidence. Very rare though, 3 per million cases after the adenovirus vaccines, the Johnson & Johnson vaccine for COVID, and it's been shown to have an increased incidence in the first 42 days after Shingrix. But however, there is also an increased incidence of Guillain-Barré syndrome after herpes zoster and an increased incidence of Guillain-Barré syndrome after influenza. So on balance, the recommendations for both are that immunization is not contraindicated, but of course one would be inquiring into the history of such a person with expert immunologic advice. As I said, a risk of about 3 in a million. Now, the next question is, do we have any updates as to when the Shingrix vaccine announced the budget for 70-year-olds will land in general practice? Well, my understanding is that this is scheduled for November, and I don't know how long after that it will take to get in general practice. We will probably just have to wait. And I remind everybody, it's only for people age 70, not for people over the age of 70 or under, which is a bit unfortunate, because that means that people over the age of 70, 71 to 79 have to pay for it, which is perhaps a bit unfair. Do we have confirmation of the immune-compromised patients that are funded by the National Immunisation Program? Very much as in the trials, people who are severely immune-compromised, so people who've had stem cell transplantation, solid organ transplantation, and also hematologic malignancies, and those people with HIV infection with a CD4 count under the age of under the number of 250, or those people who are having trouble getting above 250 with drug treatment. Interestingly, the one category that's not yet included is people with cancer and having chemotherapy, which was in fact a subject of the controlled trials. And these are people, of course, over the age of 18. And I should remind you also that with Aboriginal and Torres Strait Islanders, anybody over the age of 50 gets the vaccine free. Now, the next question I've really answered, and I agree, it's nearly $300 per dose, 2 doses, 2 to 6 months apart. So clearly it would be preferable to have this vaccine on the National Immunisation Program. And I've mentioned again that it's for people aged 70, not above 70, and for that immune-compromised group I covered in the last question. And finally, the last question, I've heard there's a 15% increased risk of shingles after COVID. Yes, this has been reported. There's a little bit of controversy around it. We will wait to see how well validated this is in subsequent follow-up reports. And the hypothesis is that this is due to the dysregulation of the immune system that certainly occurs with COVID and is responsible then for precipitating herpes zoster. And that's all the questions. Thank you very much for your questions, and I wish you all well and good luck. Thank you.